So we're going to be talking about the surgical treatment of resectable and borderline resectable pancreatic cancer. This is just a picture of the Texas Medical Center in Houston, Texas, where I'm coming from. We always appreciate visitors, so anytime anybody is willing to come or like to come visit, we're always happy to have you. So today, I'm going to touch on many of the topics that have already been discussed today, including the challenges of pancreatic diseases and pancreatic cancer, our current definition of resectable, borderline resectable, locally advanced and metastatic, and some of the emerging therapies to help treat these diseases. So as we've discussed earlier today, the challenges of pancreatic cancer, it's obviously a retroperitoneal organ, making diagnosis of the disease very challenging. And when we look at the relationship to the surrounding vasculature, that makes surgery and therapies much more challenging than other disease sites. In addition, as we had discussed earlier, currently pancreatic cancer is the third leading cause of cancer deaths, and it's soon to be the second leading cause of cancer deaths. And as we had also mentioned before, currently for where we stand, the 1-year survival for all stages of pancreatic cancer is about 25%, and the 5-year survival is 8%. So there's a lot of room for improvement. As well as, we've made tremendous progress in many other diseases. Breast cancer, colon cancer. We've really made tremendous progress. In pancreatic cancer, although we have doubled the survival, it is still abysmal for a 5-year survival, and there's a lot of room for improvement. So the pancreatic adenocarcinoma, primarily originating from the epithelial cells and ductal cells of the pancreas, tend to present within the head, and those that do present within the tail, unfortunately, present at a more advanced stage. On presentation, 15 to 20% of the patients are going to be resectable or borderline resectable. 80 to 85% of the people that present to our clinic are either metastatic or locally advanced unresectable. Of those that are able to go on to resection, it's about a 20% 5-year survival if you're able to undergo resection. So, in evaluating these patients, similar to has been discussed earlier today, there are several initial goals that we have to do. First is obtaining a histologic diagnosis, getting a tissue diagnosis so we know what we're fighting and how to treat it. Next, safely establishing biliary decompression. And then a big step from the surgical component as well as the multidisciplinary component is determining resectability. And at our center, we do this in conjunction with the surgeon, the radiologist, the medical oncologist. We all together review these images, and we try and follow some consensus criteria for how we determine whether or not these are going to be resectable or not. And then next, we determine a stage-specific treatment strategy, as has been discussed earlier today, whether we're just selecting to do adjuvant therapy, neoadjuvant therapy, how we select what these patients are getting. So the classic pancreatic cancer staging, as the TNM staging, as we've discussed earlier, is listed here. And then furthermore, we start breaking it down into these classifications: resectable, borderline resectable, locally advanced or unresectable, and metastatic. And of course, the survival numbers tend to match the presentation of each of these. So how do we define each of these? So, as I stated earlier, the relationship to the vasculature is critical. From a surgical standpoint, we pay close attention to the portal vein, the superior mesenteric vein, the celiac axis, which gives off the hepatic artery, and the superior mesenteric artery. And the relationship to these vessels is critical in determining whether or not these lesions can be cut out. So, a resectable lesion, no evidence of any metastatic disease. There has to be a clear fat plane around the celiac axis, the hepatic artery, and the superior mesenteric artery. There should not be any abutment or distortion of the superior mesenteric vein or portal vein. And generally speaking, a high-quality pancreatic protocol CT scan with arterial, venous, and delayed phases will be able to provide this. So oftentimes, our resectability is determined based on the CT scan. And you can see here, this is pancreatic tumor here. This is an axial view. You have your superior mesenteric artery here, superior mesenteric vein, very clear fat planes. indicating that this is a surgically resectable tumor, and this will provide you an R0 margin off the superior mesenteric artery. So next, how do we determine borderline resectable? So in our group, we tend to use the American Hepatobiliary Association Society for Surgical Oncology Consensus Conference for determining borderline resectable tumors. So number one, no evidence of any metastatic disease. Next, the relationship to the superior mesenteric vein and portal vein. If there is any abutment or distortion of the superior mesenteric vein or portal vein, we classify that as borderline resectable. The criteria does allow for very short segment encasement of the superior mesenteric vein or portal vein and some short segment thrombosis on this. However, I would caution that if you do have complete encasement or some thrombosis, that is pushing you closer to a locally advanced disease. In addition, there can be short segment involvement of the hepatic artery. In relationship to the celiac axis and superior mesenteric artery, it has to be less than 180 degrees involvement of the celiac axis and the superior mesenteric artery. This is a picture here, again, axial view. Pancreatic tumors here. You can see there's some abutment of the superior mesenteric vein, and there is less than 180 degrees touching the superior mesenteric artery. This is a borderline resectable, getting close to be locally advanced. In addition, another criteria that we use to the anatomic criteria are the physiologic and the oncologic criteria to determine whether or not patients are borderline resectable. And these are the classic criteria that physicians have, I think, looked at the patient, and they analyze the patient, they see them in clinic, and make a determination, and this is quantifying this a bit. And an oncologically borderline resectable patient may actually have an anatomically resectable lesion. So it may have a lesion that shows a clear flat plane and shows that it can be cut out. However, that patient may have severely elevated CA19-9, have a CT scan with some ascites on it, or have other features that make you concerned there's going to be some underlying micrometastatic disease. The other criteria that we use is physiologically borderline resectable. Once again, this may anatomically reveal a lesion that can be cut out, technically. However, that patient may have significant comorbidities, maybe an older patient, have any cardiac or pulmonary deficiencies, and that patient also would be classified as a borderline resectable patient. And then finally, there's the locally advanced disease. This is a disease that many of us unfortunately see on a regular basis. And this is greater than 180 degree involvement of the superior mesenteric artery or celiac axis and long segment involvement of the superior mesenteric vein or portal vein. And again, this is an axial view. You can see here, tumor is totally encasing superior mesenteric artery and significant involvement of the portal vein. This patient will never be able to be surgically resected. The other component, in addition to our CT scan, which is the baseline that we use for our patients to determine resectability, is the endoscopic ultrasound. The endoscopic ultrasound does give us, first of all, the tissue diagnosis to help determine treatment strategies for the patient. Second of all, the endoscopic ultrasound can give you some better sensitivity for involvement of the portal vein or the superior mesenteric artery. And this can often determine whether or not you're going to classify this patient as borderline resectable versus resectable. The other component that we use to our treatment algorithms are staging laparoscopies. So again, this would be a patient that anatomically appears to have a resectable lesion. However, you're concerned about elevated tumor markers on the patient or anything on them that is concerning for some micrometastatic disease or disease that is not being picked up on your CT scan. And as we all know, despite our high-resolution CT scans, you may have some peritoneal disease, which cannot be seen by the CT scan, or some small liver lesions. And for all of our clinical trials, we do a staging laparoscopy on our patients before they start neoadjuvant therapy or any other patients in which we are trying to determine a stage-specific treatment strategy for them. So once we have classified this patient as resectable, borderline resectable, locally advanced or metastatic, how do we treat this patient? So I'm a surgeon. I'm going to tell you that surgery is going to be the most effective treatment for pancreatic cancer. Stage for stage, if a patient can undergo surgery, they are going to have better outcomes. As we all know, the Whipple procedure was first done by Alan O. Whipple in 1935. At that time, it had a 30-day mortality of close to 50%, and it was plagued by pancreatic fistula and delayed gastric emptying. The Whipple, as we all know, involves revealing the anterior surface of the pancreas, and then you have to dissect away the pancreas from the portal vein, superior mesenteric vein, divide the neck of the pancreas, divide the bile ducts, divide the stomach or duodenum, and divide the ligament of Treitz. And the dissection involves this meticulous tying off of blood vessels off of the portal vein. The specimen, then sent to pathology, has the pancreatic neck to evaluate, the bile duct to evaluate, and the superior mesenteric artery to evaluate. And then the reconstruction involves your pancreaticojejunostomy, your hepaticojejunostomy, and your gastrojejunostomy. And a lot of the morbidity is driven by this, your pancreaticojejunostomy. In general, it tends to be about a 2 to 3 millimeter duct that we have to anastomose to the jejunum, and this is where the majority of the morbidity is driven from this operation. This is the anastomosis after completed. We have improved significantly over time. So the mortality from this operation has continued to improve. I would argue that at all high-volume centers, the mortality for this operation should be less than 3% or less at 1% or less at most high-volume centers. This is some data from Memorial Sloan Kettering showing their improvement over the past 3 decades, decade by decade, in overall mortality, complications, and length of stay. However, as we've discussed, pancreatic cancer is a systemic disease. And despite the surgeon's best efforts, it is a systemic disease that will come back without either adjuvant or neoadjuvant therapy. So as we mentioned earlier, the CONCO-1 trial sort of gave us the backbone of treatment with gemcitabine versus observation for adjuvant treatment of these patients, and took them from a 21% 5-year survival to 9% if it was not given. As listed earlier today, there's been a slew of other adjuvant trials looking at various other therapies. As a whole, from our group, we do believe heavily in adjuvant therapy, whether it's a gemcitabine-based or 5-FU-based therapy. The opinion on radiation therapy afterwards, I think the jury is still out on the utilization of it. We use it selectively, either for close margins or any concerns for any local disease, but clearly adjuvant therapy has to be a backbone of treatment for it. So what about neoadjuvant therapy? So as was discussed earlier, in the CONCO-1 trial, 25 to 30% of those patients never got any therapy, either because they had a myocardial infarction afterwards, a pulmonary embolus, a pancreatic fistula, they got so debilitated, they were never able to make it to therapy. So clearly, there's going to be a percentage of patients who are never going to get that adjuvant therapy that we know is going to prolong their survival. The other concept that has been a bit tougher to play out within the literature is improvement of rates of surgical resection and R0 resection rate. When I was at University of Pittsburgh, we did a trial looking at gemcitabine, radiation, and Avastin, trying to look specifically at the R0 resection rate and see if there was an improvement on this. And this has been one that, theoretically, as a surgeon, it makes sense. However, it's been difficult to actually play that out within the surgical literature. The other concept that exists for neoadjuvant therapy is the fact that there's an intact vasculature. That after the patient's had a Whipple procedure done, they've had all these tributaries tied off, and the therapies are not going to get to the area. And the idea is that in a neoadjuvant setting, the tumor is going to be able to get these therapies to it. In addition, there's the concept that time is going to allow any unmasked micrometastatic disease or other disease to appear during the time of the neoadjuvant treatment. And it's essentially a patient selection process. By giving these patients neoadjuvant therapy, you're allowing them to self-select out those who really have micrometastatic disease to come up and show its head, and those patients would not have benefited from a surgical resection. As mentioned earlier, Doug Evans, before he left for Medical College, Wisconsin, did a very nice trial of resectable head lesions, giving him neoadjuvant gemcitabine and full-dose radiation. He was able to show a 36-month survival in these patients, significantly better than previously reported. The one caveat to this was these were all head lesions that were clearly resectable, basically a heavily selected patient population. However, there is an indication that neoadjuvant therapy in many patients is going to offer a benefit. So what are some of the chemotherapeutic advances that we've had recently? So, as we had mentioned, gemcitabine has been a backbone of therapy. As you all know, for the stage 4 pancreatic cancer, we were able to analyze gemcitabine and Abraxane, and you were able to take these patients from a 6-month overall survival to an 8.5-month overall survival. More impressive was the New England Journal of Medicine study with FOLFIRINOX, showing, this is again stage 4 patients, that they were able to go from a 6-month to almost a 12-month, nearly doubling their overall survival. And with these new regimens in place, we have trials that are across the country going on, looking at doing these in the adjuvant setting as well as a neoadjuvant setting. And I think there's some hope that we're going to make some progress with these new therapies. Some of the technical advances as well, as shown earlier today, vascular resection. So this was a study done by Jenny Chang, looking at patients who underwent pancreatic resection with vascular resection. She was able to show that they essentially have similar perioperative morbidity and mortality and similar overall survivals for this. In our center, as well as most high-volume centers, there's going to be about a 10 to 15% vascular resection rate, and there's a wide range of vascular resections that we can do. You can do an end-to-end resection of superior mesenteric vein, portal vein. You can take internal jugular graft to plug it in to replace it, or you can do a patch repair as well. And the determination of whether you're going to do a vascular resection oftentimes is made preoperatively, but similarly is made at the time of surgical resection. This is just some of our data looking at our vein resections in these patients. Very similar overall outcomes. We did find a slightly increased rate of thrombosis in these patients in terms of pulmonary embolus afterwards, things like that. And for that reason, we have a regimen for our patients to undergo vascular resection where they're put on systemic anticoagulation for a 3-month period afterwards. Some of the other progresses that we've made. So minimally invasive pancreatic surgery. So, as we first mentioned, the Whipple was done in 1935. Gagne and Pomp first described a laparoscopic Whipple in 1994. Soon thereafter, they did a laparoscopic distal pancreatectomy. First robotic Whipple was done in 2003. The technique, when it was first proposed, was met with a lot of resistance with concern for oncologic outcomes. Why do you want to proceed with a minimally invasive approach? Well, as we mentioned earlier, there's still this concept out there that these are severely morbid operations and patients are simply not being referred to surgeons. And this is an article by Carl Bilmora. This is looking at stage 1 pancreatic cancer. So a patient with early stage pancreatic cancer. 74% of these people were never offered surgery. And this was any number of reasons. Either their referring doctor felt they had too many comorbidities, they were too old, simply not being offered surgery. And I think part of this is because people are concerned about the morbidity and mortality that relates to these pancreatic cancers and the operations that it requires to resect them. And so when you proceed with any minimally invasive therapy, you want to make sure that you're having reproducible outcomes. You essentially want to do the same operation you do open as you do minimally invasively. You want to make sure that you're not harming the patient when you do it, and then ideally what you want to look for is see if there's any potential advantages, such as decreased perioperative morbidity and mortality. As we discussed earlier, there are still significant complications from this operation, as well as potentially get these patients to earlier adjuvant therapy, because adjuvant therapy is what's going to prolong their life. In our group, as we've done this, we've rolled out the robotic Whipple procedure. We've done a high volume of the laparoscopic and robotic distal pancreatectomies, and you basically have to select patients that are appropriate for the operation, so you're not harming patients. This is just from our center, sort of the volume of minimally invasive surgeries you can see has increased over the years. You can see a lot of that has been driven by the minimally invasive distal pancreatectomy. However, the robotic Whipple has increased our rates of minimally invasive pancreatic surgery as well. We looked back at our data, looking at the open versus laparoscopic versus hand-assisted versus robotic for the distal pancreatectomies. And in our hands, we had very similar outcomes. Throughout the groups, they were very equivalent in terms of fistula complications afterwards. Similarly, in the small cohort of the robotic Whipples that we've done, the patients have done acceptably very well. Very low rate of grade 3 complications, and overall have done very, very well. So, in terms of the minimally invasive therapy, it is moving nationally. It is becoming a larger component. The NCDB data has shown about 15% of the pancreatic resections are being done minimally invasive. You have to make sure you're doing it safely and selecting the right patients as you're doing this. In addition, you have to address the fact that this should be done by surgeons that do a high volume of minimally invasive as well as pancreatic surgery. So what are some of the other advances that are coming forward in terms of treatment of pancreatic cancer? So as we had discussed, the surgical resection of these is a key component. However, the systemic therapy really is the driving component. Within our group, we have a collection of basic scientists as well as surgeons, medical oncologists, gastroenterologists, who all work together. We have weekly lab meetings as well as weekly multidisciplinary tumor boards. We have a collection of hospitals that see these patients, and we try to do a bench-to-bedside concept where we work very closely with our basic scientists and our clinicians and try and cross diseases and ideas over to treat these diseases rapidly. Some of the concepts that we've come up recently were part of a large national trial looking at early diagnosis for pancreatic cancer. So in some of these patients, we started to collect saliva, stool, pancreatic juices, and analyze the microbiome of these patients with the idea that you can come up with an early diagnostic test and see if something can be changed within the microbiome that will help you diagnose these therapies, diagnose these cancers earlier. In addition, very exciting, we have started a phase 1 trial that's going to be an adoptive T-cell immunotherapy. And this is a concept that this is a disease that is persistent. Despite adjuvant therapy or neoadjuvant therapy, it often does come back. And in our lab, we have come to find that there's been significant improvement with the immunotherapy. And this is taking the patient's own T cells out of them, transducing them with a CAR T cell, and then reinfusing them into the patient, and essentially getting your own T cells to help treat the disease. And the idea of this is that you infuse this at the beginning of therapy, the beginning of adjuvant therapy, do another infusion after the surgery, and then do another infusion after the adjuvant therapy that follows on the patients. Furthermore, we've run numerous other trials, many of them looking at the immunologic therapies. We've had several of the vaccine studies that have been open for these patients, and we're doing these in conjunction with our standard of care treatments. And I think, truthfully, that's where we're going to make some progress, is taking these backbone therapies that we have and using some other adjuvant therapies with it, such as immunotherapies, vaccines, to try and make some improvement in these diseases. In addition, we do bank all of our tumors, and we work very heavily with our basic scientist colleagues and researchers to use these tumors in as efficient a method as possible. This is just a list of all of the banked tumors that we have and use readily available for our researcher colleagues. So, in conclusion, we must continue to advance. We've improved significantly in pancreatic surgery, and I think we can safely do the surgery and provide the patients a good quality outcome from this. However, pancreatic cancer remains a systemic disease. In the setting of a borderline resectable tumor, we believe that all these patients should get neoadjuvant therapy, and in the setting of potentially resectable diseases, those patients should also be getting neoadjuvant therapy as well. Overall survival, and this is going to depend on newer therapies and innovative therapies to improve the survival. Thank everybody for having me up here.